cause. Ventral median hypothalamus lesioning on the converse leads to obesity, and low frequency of stimulation of the ventral hypothalamus inhibited feeding and led to kind of abolition of the trend towards obesity. Nucleus accumbens is also, because of the various connections of the nucleus accumbens to the limbic system and to entorhinal cortex. And the nucleus accumbens is also believed to be a modulation center for reward and sensation associated with palatability of foods. So for instance, when you measure neuronal firing rates, with high sucrose diet, it tends to lead to increased neural firings in the nucleus accumbens. And the reason why we like high saturated fat food is because high fat actually leads to dopamine release, and that leads to, it's a pleasurable response. So that's why we kind of crave these fatty steaks, wagyu beef and all that, because actually fat leads to dopamine release, you know, and therefore destruction of dopamine. If you want to go on a diet, actually kind of destroy your, you just inhibit your dopamine neurons, and you will actually not hot food. You will actually eat less, and you will actually lose weight. So you just need to take dopamine. You just need to take dopamine antagonists, and probably you will lose some weight because it will abolish some of the pleasure effects from eating high-fat food. So this is a study in 2012 by DeSalas, DBS for obesity, where they stimulated the ventral median hypothalamus in mini pigs and showed that there was a weight loss in the mini pigs that underwent DBS. So 6.1 kg weight loss over, 6.1 kg weight gain versus 9.4 kg weight gain. And the ones on DBS actually gained less weight than those off DBS in the control groups. So ventral median hypothalamus, but this is animal studies, not done in humans. So largely all these studies are in humans. Anorexia nervosa, so the converse, you want to do DBS for obesity. On the other hand, what about DBS for patients that now refuse to eat? So there are some animal studies in Wistar rats that shows that electrical stimulation, electrohypothalamus, does actually promote feeding in the rodent model. But again, animal studies, although in China, Bobinson in Shanghai does do lesioning for anorexia nervosa, but not DBS. So Bobinson has been doing some lesioning work for patients with anorexia nervosa in Shanghai. But then again, there are some other studies that shows that, it also in animals that didn't show that positive findings with DBS in rodents, where there's no significant effects on food intake as well. Then moving on to the realm, right, where we go from psychiatric disease to anorexia and bulimia and obesity. Now you're moving further into this realm of what is disease and what is behavior, addiction. Nucleus accumbens is a pleasure center. So Vasola did these studies where they made rats addicted to cocaine, and then they performed DBS in the nucleus accumbens regions of the rodents. And when these rodents had DBS of the nucleus accumbens, they then actually crave less cocaine. So therefore, these animal experiments demonstrate that nucleus accumbens can attenuate cocaine priming induced reinstatement of drug-seeking rodents. So possibly this may be a target. You can actually set up shop outside Resorts World for this if it really works. You can set up a clinic in MBS. Yeah. And then now moving on to the next frontier, which is memory and dementia. So these are some of the circuits. Important circuits to note and targets to note would be mammillary body and the nuclear bacillus of mainnet, which is in the inferior frontal lobe, quite close to CG25 region. So these are the circuits that eventually, ultimately, actually drive down to the hippocampal region, either through the fornix or through a basal tract. And we know that memory is actually formed in the hippocampus. With neurogenesis happens hippocampus, and it's the hippocampus that actually allows us to formulate new memories. Whereas long-term memories are stored in the rest of the brain, but memory formation is actually coordinated in the hippocampus. So these are a list of all the targets that have been used or studied for the treatment of dementia, largely fornix, which is the mammillary body region, or the nucleus basilis of mainnet. So these are the two targets that have been largely used by various neurosurgeons. Numbers of trials range between 1 to 42. So these are the numbers that we study. Generally not large numbers. So this is a study using the NB target, 6 patients bilateral low frequency DBS, and 4 patients were found to be stable or improved based on ADA assessment scale. So this is using the basal nucleus of mainnet target. The other group, this is another group, unfortunately, which showed similarly 6 patients, same target, but no improvement. So there are positive studies and negative studies, so still a little bit early. If we look at some of the metabolic imaging of, again, because of the advances in neuroimaging, and particularly metabolism, this has helped us understand that when you actually do DBS of the fornix in patients with mild Alzheimer's disease, it does result in increased cerebral glucose metabolism. But unfortunately, in this advanced trial, although functional imaging and blood flow imaging show increased blood flow and glucose metabolism, but in terms of cognitive outcomes, it was inconclusive. Yeah, so this is actually the Toronto study that had some positive studies in phase 1 trial, but then when they went to the phase 2 trial, then unfortunately didn't show benefit. But the promise of this study was that it was the first time in the world that when you did volumetric analysis of the mammillary bodies of the, not mammillary bodies, of the hippocampus, because for dementia, actually, if you quantify the hippocampal volume over time, patients with dementia lose hippocampal volume and mass. For the first time, actually, what this advanced trial and the early phase 1 trial in the Toronto group, what it exhibited was that it's the first time that there was documented arrest of hippocampal volume decrease in patients with dementia. So 2 out of the 6 patients actually did not have progressive loss of hippocampal volume. So I think that's some other positive findings, but unfortunately, in terms of clinical outcome, it's still inconclusive. Right? So this is where we stand currently in the DBS for Alzheimer's disease space. I think some other issues that will crop up is the realm of neuroethics. Neuroethics, as defined by Pontius, is basically talks about the definition of neuroethics and emphasizes the ethical, legal, and social implications of neuroscience. William Safire says that neuroethics is the examination of what is right or wrong, good and bad about the treatment of perfection of or unwelcome invasion of and worrisome manipulation of the human brain. So certainly some areas that we need to think about for neuroethics are in areas of neuroimaging, pharmacological and psychological intervention, neurosurgery, psychosurgery, and neurostimulation, and also in the certification of brain death and what is brain death. And the reason why psychosurgery particularly is affected and influenced by the realm of neuroethics is because psychosurgery can actually target one's personal identity, which defines all the features unique to an individual, the attributes, their personal attributes, their characteristics, their personal memories, and also the need to respect inter-individual variabilities of personal attributes, personal memories, and personal experiences. So if you look at it, what's the patient's perspective? And this was a study that looked at, that actually asked qualitative information on what is important to patients when they undergo neurosurgery. What's the, I guess, and these were some of the things patients, talked about. It's not a concern to lose identity if, when patients choose between threat to identity and threat to physical existence. So for instance, you have an aneurysm, or you have a brain tumor, or you have an AVM, the threat of identity loss, personality loss to patients is not so good when it balanced, when traced between the choice between threat to identity and threat to physical existence. Patients will always choose to prolong physical existence despite the risk of personal identity or personality. But when it's things when there is less threat to life, or threat to life or physical existence, then that's when stronger stringent control surgery on the brain to control treatment or refractory psychiatric disease, etc., becomes a bit more controversial. But within the realm of refractory psychiatric disease, when patients are interviewed, generally they feel that that is something that is acceptable to them. But when balanced between surgery with the explicit aim to alter identity, modify, or enhance either normal or maladaptive traits, these two patients, they feel that this is ethically dubious. Yeah, so when it crosses the realm, it's when is psychiatric disease a disease, and when is it just a maladaptive social trait or personality trait? That's when it becomes blur, and that is when that patients feel that it is no longer acceptable. This particular study also interviewed neurosurgeons, and taking into account that different neurosurgeons, everyone has slightly different personal instincts and ethical principles that will govern their responses. So the neurosurgeons interviewed in North America generally feel that surgery for refractory psychiatric disease is ethically justified. All the neurosurgeons generally felt that surgery to enhance non-pathological traits is unethical. And I think generally people accept that cultural attitudes and social norms will govern the acceptability of surgical innovation moving forward. So this is where we are at now. Actually, both patients as well as neurosurgeons and physicians. Neurological disease such as Parkinson's disease, Huntington's, dyskinesias, dystonias, fully acceptable. Psychiatric disease, depression, and OCDs, actually the vast majority generally within the medical, surgical, as well as patient and community, it is considered that DBS is acceptable. But maladaptive traits, obesity, addiction, eating disorders, certainly when you move towards traits such as anger control management, greed, melancholy, happiness, optimism, intelligence. Currently, the majority, both society, general society, patient population, as well as physician and surgical population, this is the current state that no one feels that these are ethically permissible to actually adopt DBS. Yeah. So the thing is, I think the same controversies were faced with IVF. 1950s when IVF research was first basically commenced. 1969 we saw the first fertilized human embryo, and 25th July 1978 the first IVF baby was formed. Louis Brown, who would today be actually close to 40, will be in the 40s. So I think, the similar controversies were encountered by the IVF kind of science. And I think it was only in, the 2000s, 1990s, and then finally Robert Edwards won the Nobel Prize for Medicine for his work in 2010 for his IVF research work. So I think if we are able to, study and move in in a calibrated fashion, in an ethical fashion. I think in the future we can see. I believe that with greater understanding of psychiatric illness, with better science, better understanding of neurochemistry, neuroanatomy, and neurocircuitry, being able to do surgery accurately and more minimally invasively, I think that over time, if we walk this ethical route in a sensitive way, we will increasingly gain more social and cultural acceptance for surgery for psychiatric disease. Yeah, thanks.
Thank you so much, Prof. That was certainly a very thought-provoking talk. Any questions for Prof. Waihoe?